Hello, everyone. Thank you for joining us tonight on the first installation of ABC's Women and Children's Committee podcast titled Hot Cocoa with Hot Shots. ABC, the Association of Black Cardiologists, was founded in 1974 by cardiologists eager to eliminate the disparities that exist related to cardiovascular disease in communities of color. The Women and Children's Committee was started in the last year to highlight the spectrum of cardiovascular disease from childhood to women in their reproductive years to postmenopausal women in communities of color. With our newest series, Hot Cocoa with Hot Shots, we'll have insightful, focused, one-on-one interviews with hot shots, those making moves in the world of pediatric and adult cardiology. Today's program will cover the worlds of artificial intelligence and peripartum cardiomyopathy. Without further ado, I'll now turn it over to my Women and Children's co-chair, Dr. Rachel Bond.
Thank you so much, Dr. Ansong. We are so looking forward to this wonderful talk today. So I'm actually very honored to introduce both our moderator as well as our guest panelist who will be talking about artificial intelligence. As Dr. Ansong mentioned, I am an adult cardiologist and I'm her co-chair for the Women and Children's Committee. I also practice in Arizona where I oversee a women's cardiovascular program. I'd first like to introduce Dr. Demilade Adedin-Shewo. She is currently an assistant professor of medicine and a non-invasive cardiologist at Mayo Clinic in Florida with a clinical focus on women's heart health and echocardiography. She is a fellow of the American College of Cardiology, and her research interests include cardiovascular disease in women and the applications of artificial intelligence tools in cardiovascular disease detection. She is currently a women's health scholar, and her research is supported by the Mayo Clinic Women's Health Research Center, as well as the Mayo Clinic Building Interdisciplinary Research Career in Women's Health program, which is funded by the National Institute of Health. She also most recently has received a Master's of Public Health degree from Emory University and a professional certificate degree in machine learning and artificial intelligence at the Massachusetts Institute of Technology. I will now like to also introduce our moderator for the day. Our current moderator is a member of the Women and Children's Committee for the Association of Black Cardiologists, and her name is Dr. Joyce Jiroge. Dr. Jiroge is a cardiovascular disease fellow at the University of California, San Francisco. She plans to pursue advanced heart failure training with an interest in inherited cardiomyopathies and healthcare disparities. She's been involved in research pertaining to peripartum cardiomyopathy and risk stratification for subsequent pregnancies, as well as evaluation of heart failure groups on a genetic level. Dr. Jiroge earned her medical degree from Case Western Reserve University School of Medicine in Cleveland before completing her internal medicine residency at the McGough Medical Center of Northwestern University in Chicago. Without any further notice, I'm going to hand it over to Dr. Jiroge to get this conversation started.
Thank you, Dr. Bond and Dr. Ansong for that wonderful introduction. And welcome, everyone. I'm very excited for our conversation here with Dr. Adedin-Shewo. Demi, how are you doing today?
Hi, Joyce.
So as we get started, can you tell us a little bit about cardiovascular disease in women, just overall? What are some things that women should know and be on the lookout for?
Wonderful, great question, Joyce. Just to get started, I am Dr. Adedin-Shewo, and I'm a non-invasive cardiologist at Mayo Clinic. So yes, cardiovascular disease is the leading cause of death among women in the United States and also worldwide. It's responsible for up to 1 in 3 deaths. It's also the leading cause of pregnancy-related deaths. In addition, it's estimated that up to 90% of women have at least one risk factor for cardiovascular disease, unfortunately. The other thing I want to point out is that there are some specific non-traditional risk factors for heart disease in women. And one that is particularly unique to women are adverse pregnancy outcomes. And we are finding out a lot more about that. And this includes gestational diabetes, pregnancy-related hypertension, having a small for gestational age baby, or having a miscarriage or pregnancy loss. Also, cardiovascular disease tends to come with a higher risk among African American women. So Black women is the higher risk of dying from heart disease compared to a white woman.
Thank you. Yeah, those are really interesting facts that I don't think are as commonly noted. But it's really good to help educate the masses about this information. And we also try to figure out ways to advance our care and management of these women. So can you tell me about artificial intelligence and kind of, this exciting field, how it may relate to cardiovascular disease and specifically in our women?
Yes, I would love to. So artificial intelligence, short for AI, moving forward as we discuss this, has been defined as really the science and engineering of creating intelligent machines. And I want to say that a number of people have also pointed out that this is a misnomer because, machines are not really intelligent in the real sense of it. But machine learning and artificial intelligence, I would say machine learning is a subtype of artificial intelligence that allows us to give a computer the ability to learn without explicitly programming it that way, because programming a machine to perform some of these complex tasks can be really difficult to do. And this is why machine learning tends to excel when it comes to analyzing very large data sets and complex data sets. There's a more common type of artificial intelligence or machine learning called deep learning. And this is the one that is commonly used in the space of, cardiology and in a lot of the interesting research that we're beginning to see now. It basically works in a similar way as the human brain. It was basically modeled off of a neuron. So that's why it's also called like a deep neural network, is kind of like a common term that we use to describe it. So there are multiple nodes and there are multiple connections as well as multiple layers. But in fact, the real sense of it, deep learning or machine learning really just extends some of the common regression techniques that we're used to and a lot of mathematical equations that are happening on the back end, such that this is happening simultaneously and really quickly that we're able to get predictions and results from it.
It's really exciting things in that field. And it's really cool to me to see how this that's been applied in other fields is now coming to medicine and cardiology specifically. So I know that you do a lot of research in this field, and I was wondering if you can personalize this a little bit and tell us about your research in AI and why are you interested in cardiac disease, especially in pregnancy?
Sure, I'd love to. So before I talk about my research, just in general in the field of cardiology, there's been a real increase in the number of articles that are addressing or using artificial intelligence methods for diagnostic purposes in cardiology. So we've seen a lot of studies that are using data from the electrocardiogram, which is the ECG, to predict cardiac conditions such as a low ejection fraction, which normally you wouldn't be able to tell by looking at the ECG, but you would need an echocardiogram for this. Other things that they can predict includes things like amyloidosis, amyloid heart disease specifically, the probability of hypertrophic cardiomyopathy, aortic stenosis, mitral regurgitation, and so many other different conditions. It's also being used in risk stratification for like realistic patients in the ICU, finding different phenotypes of heart failure. And there's just like, a lot of different studies that we can talk about today. So I'm going to bring this back home and kind of circle it back to my study in particular, which I am looking at the ability of an electrocardiogram that is enhanced with artificial intelligence to detect cardiomyopathies during pregnancy and in the postpartum period. So why am I interested in this? Maternal mortality in the US has been on the upward trend over the last 3 decades, I would say. And when you compare the trends in the US to other developed countries, the US appears to be performing much worse. And looking at the top reasons why women are dying during this critical time period, really cardiovascular disease is the leading cause, like I mentioned earlier. When we subset all of these cardiovascular conditions, cardiomyopathy happens to be ranking at the top of one of the reasons why women are dying. A lot of this has been, postulated to be related to the challenges of diagnosing cardiomyopathy during this time. So a lot of the symptoms of normal pregnancy sometimes can overlap with the symptoms that we see with cardiomyopathy or heart failure. So things like lower extremity swelling, shortness of breath, or orthopnea. And if a patient complains of this to their OB or their provider, it is difficult for you to tell, do they have heart failure or are these normal pregnancy symptoms? So all of these challenges leads to a delay in the diagnosis and also leads to poor outcomes with cardiomyopathy. So clearly there's a need for an effective screening tool for this patient population. The closest thing we have is to get a blood test, which is the BNP, which is not perfect in this population, or you get an echocardiogram. So an echocardiogram is not something that is readily available to the OB or that an obstetrician will order. So can we find something else that is readily available in a clinical setting that we can use to screen women? And can we scale this tool? So that is how I decided to work on this. And because the Mayo Clinic was able to develop a model that uses the 12-lead ECG to predict the low ejection fraction. Our goal is to take this existing algorithm to the obstetric population to see, does it work well? Can we use this, and will this be a useful screening tool in this patient population?
That's amazing. Yeah, because I know electrocardiograms are pretty easy to get no matter where you are, emergency room, whether you're visiting your OB, they can get that done with minimal technicality. Whereas echocardiograms, as you were mentioning, they're a little bit of a, although readily available resource, it's still a bit limited, especially in the OB. So that's really amazing work that you're doing. Where do you see this going in the next few years, the field of AI, especially within cardiology and with women's cardiovascular disease?
So the field truly is exciting, but I want to say it's still in its infancy. I think that it will still take us some time before we can start to translate some of this research findings into clinical practice. So far, with some of our work, we've been able to show that this AI ECG model is effective in pregnant and postpartum women in identifying cardiomyopathy with an AUC of 0.92, and our results were published about 3 months ago in the European Heart Journal, Digital Health. Right now, we're working on studies, prospective studies, to make sure that this tool is still effective when these women are enrolled prospectively. Our goal is to also evaluate how well this model does in diverse patient populations, because sometimes we know that AI models, even though they're great, they come with their own downside. They're also subject to some of the errors and biases that may be in the data sets that we use to train them. So we want to be sure that when you take this, algorithm outside of the Mayo Clinic environment, Mayo Clinic patients, and we start to apply it in different settings, does it remain effective? And then one of the more important things, we want to be sure about before we start using these models is, does it improve clinical outcomes? Because that's the overall goal, right, of finding something, early diagnosis. If you diagnose a condition early, but still you don't do anything about it, then you haven't really changed the trajectory or the course of that disease. So we have to be sure, apart from validating them in large, diverse patient populations, we want to make sure that they have a positive impact on clinical outcomes. The other downstream thing we also need to figure out is, how much of a burden will this create on the healthcare system when it comes to cost? Will this cause us to order more echocardiograms because of the positive flags or not? So all of those things kind of still need to be evaluated. So longitudinal studies, validation studies, clinical trials really are critical for us to do or perform before we can start to move AI more into clinical practice. I am hopeful, though, that over the next 5 years, that we can start to incorporate these technologies in clinical practice. We can start to see an improvement. We can start to level the playing field somewhat so that we can scale this technology to reach underserved patients as well as underrepresented patients. So that's my hope. That's what I am hoping to see in the future with this.
That was very thoughtful and very thorough. Thank you so much. This was incredibly interesting, Demi. Thank you for joining us, everyone.
Thank you so much, Joyce, for having me. This was great.
Hey, everyone. We'll take a second now and see if anyone has any questions that we can answer. Please feel free to put them in the chat. I know people are watching on Facebook as well, so we'll be monitoring for any questions that may come up. I have an anonymous question. Dr. Bond briefly touched on your background at the beginning, but can you share more about how you became involved in AI, machine learning as a cardiologist? I think this is for Demi.
Sure, I'd love to do that. Hopefully you can hear me. So I would say I developed an interest in AI towards the end of my fellowship training, actually. That's cardiology fellowship training. I had seen some articles and I got to know some of my consultants that were working in this space, and I got to meet one of them. And, we had a conversation about it. And I was like, how do I get involved in this space? This is new. This is something very interesting. Is this something that could potentially change, how we provide care to patients? And they're like, sure, if you want to learn more about it, you can come into our meetings. And luckily, a project opened up at the time that I was able to collaborate on and work with them on. As part of my fellowship training at the time, I had the opportunity to apply for a scholarship for additional graduate education. And, I guess, I am not tired of like schooling and education. So I applied for this, and this basically covered the cost of my training at MIT, which is the professional certificate that I got in machine learning and AI. And just taking all of those classes and going through that program kind of helped me understand a lot of the, background information and how, machine learning works and what does AI mean. And I also got the opportunity to do a little bit of hands-on programming. So my background also includes epidemiology. I have an MPH, and I spent 2 years at the CDC as a data analyst before my residency program. So I actually have, some experience with programming codes. So I wasn't terrified of learning something new. So this was a whole new programming language called Python, and I was just really excited to learn more about it. And then I guess with that experience, the educational experience and the opportunity to actually participate in a clinical study and then bring in my own clinical background and perspective to it is kind of like what made that perfect mix for me. I was able to say, okay, this is a question that I have clinically, and is this appropriate for AI to address? Is this appropriate for machine learning to address? And for me, that was how I got involved.
It's a really great example in highlighting the importance of great mentors who can really introduce things that will essentially change your life. That's amazing. Another question here, what are some limitations you envision with using AI in this specific clinical situation?
So I may have touched on this a little bit during our initial conversation about how AI, even though it comes with a lot of great things, remarkable performance. We see all of this like studies, we see AUCs 0.9 and above, just truly remarkable. A lot of the standard cardiovascular testing that we have, take for instance, like a stress echo, do not even have AUCs in this range. Our AUCs are like in the 0.8 range, some of them 0.7. So really it is outperforming a lot of the things that we know that we do, that we consider like kind of the gold standard of care right now. But it does have drawbacks that we really need to be aware of. And one of them includes bias. So what happens with AI models is they tend to learn a lot from the data sets that we use to train them. So if data sets that are being used to train these models have inherent bias, which we know exists already, right, in the cardiovascular world as we know it, then AI kind of has the potential to perpetuate or propagate this bias even on a larger scale if we don't identify them. There was an article that my team and I just recently published about 6 days ago talking about leveraging machine learning and AI for cardiovascular disease screening. And we do go into detail about how bias can be a big issue with models and how can we, address this, which is making sure that we are being inclusive, the patient populations that we're using to train this model, that we are also validating these models in diverse patient populations, that these models go through rigorous testing, and that over time we are reevaluating them to make sure that they are stable, they're continuing to do well, and it's not just kind of like, this one size fits all approach without actually testing them thoroughly. So that's one of the downsides that AI can have. The other thing again is, how well does digital technology permeate? How can we get this into, different places such that we are not also making disparity is worse. So, digital health and digital technologies now are being viewed as a social determinant of health because, there are communities that will be marginalized by just not having access to things like the internet, broadband connection. And we want to make sure that once we are moving towards these technologies, even telemedicine, we started to see that some communities were left behind with that we are able to get this out there. So take, for instance, the 12-lead ECG that I talked about in the study that I'm working on. While it's easily, available, and, you can do this with minimal skill, there are also different types of an ECG. There are environments where you get an ECG and you're not able to get the digital data off of the machines. The ECGs are printed on paper. This makes it challenging for you to run a paper ECG through an AI algorithm. So there are some other things that we're finding out that will be challenges before we get this really to that point where you can take it anywhere. And now we are looking at other things like, portable devices that can record an ECG. So for instance, like the Apple Watch or any of the other smartwatches now that can record an ECG, or portable devices that have FDA approval that do not require any fancy machine or equipment. So the digital stethoscopes, they can also record ECGs. Can we use that? And those, that data is already available in an electronic format, and we don't have to convert it. And can we use get AI-based predictions off of these devices so that we can basically take them anywhere, like even international locations, so long as you're in a place that has internet connection and having it work. So there's definitely a lot that we can talk about. There's a lot to work through. And, there's opportunities for more research in this field to understand how best we can get this to clinical practice and to our patients.
And can you clarify, you mentioned it a couple of times, AUC, what it means and how it's a marker of success or effectiveness?
Absolutely. Yes. So an AUC is also called the area under the curve. And it's a very common metric that we use in diagnostic medicine to see how well does a test do in identify whether somebody really good, but AUC of 0.9 and above is considered like truly excellent performance of a diagnostic test. And there are very, very few, testing tools that actually are this remarkable that perform this well.
Thank you. We have a couple of other questions in the chat. So what other conditions do you envision this technology being applicable for as we learn more about it, more about its use and more about its effectiveness?
So I can talk a little bit about some of the studies that are going on at Mayo Clinic, and I mentioned some of this earlier. There are ECG-based AI algorithms now that can detect the presence of cardiac amyloidosis, can detect the presence of aortic stenosis just with the ECG, so without getting an echo, and things like, hypertrophic cardiomyopathy. And we're looking at applications like, can we use this for like, screening young patients, like, people that want to participate in sports? Will this become a useful tool? Because we know the ECG by itself is not a great screener for, young patients that want to participate in sports. And same thing for cardiac amyloidosis because of, the delayed diagnosis, and sometimes we miss this diagnosis. And this is just speaking about ECG alone. There are other AI models now that use other diagnostic, tools like, echocardiograms, the CT, the MRI, and they're able to use some of this to predict cardiovascular risk. There's one of them that is able to automatically calculate what we call breast arterial calcification from a routine mammogram and use that to predict cardiovascular risk. And this is one of the things we talked about in that paper I mentioned that was published in Circulation Research. Can we start to use some of the things that women are already going to get screened for, like a mammogram? And can we get additional information from this by analyzing it with AI to predict cardiovascular risk? And can we identify who's high risk, who needs to see their doctor early, who needs to start statin therapy and things like that? And can we start to improve cardiovascular care for women?
That's wonderful. One of the conditions you mentioned, amyloid cardiomyopathy, that's really amazing to hear because it's often underdiagnosed. And many people may be walking around with the condition without noticing it until they start having true heart failure symptoms. So this early diagnosis and early detection is very interesting. I think we have one more question we can take. How does a cardiologist get involved in AI and incorporate this into our clinical practices?
So excellent question. And I do think that just because of how new the field is, you will need to work with a team to be able to kind of get involved if you want to do AI research. This is not something I feel like it's easy to start up and do on your own, except if you have the background and you have the training. We have so many different people coming into medicine now, coming with different backgrounds. So here at Mayo Clinic, I work with a bigger team. So even though I have an understanding, I spent some time learning a little bit more about the programming. I don't do all of the programming myself. We have data scientists and data engineers that this is what they train to do, and they're much better at doing this than I am. It's just like, when you have a physician and you work with a statistician, because, they are much better at doing this. This is kind of like, how the field works. But I do feel like I mentioned earlier, it takes a whole team effort, because there are different parts of it that your data scientist and your data engineering understands. But as a clinician, we understand the needs. We understand what we are trying to, diagnose a little bit better. We understand our patient population. We also know where the challenges are. We also know the limitations of our current diagnostic tools, what we can and we cannot do. And we bring that knowledge, and that helps to complement the right research questions, knowing what things do we feel like AI can close the gap for us. So I think that cardiologists will have a huge role to play, radiologists, pathologists, mostly I think a lot of physicians that work with image-based diagnostic tools and stuff that has a lot of data points that sometimes it's difficult for us to ingest all of that information. There might be a role for AI to help us ingest all of this data, simplify it, and provide useful information that we can use to better care for our patients.
In the last minute, Demi, thank you first and foremost. I really wanted to thank you for really giving us a nice overview of artificial intelligence and all the work that you're doing. I did have a very brief question though, because a lot of your research is focused on the obstetric patient. So did that require a lot of education to your obstetrician colleagues in terms of even the utilization of an EKG? Although, as Joyce mentioned, it's readily available, it's not something routinely done in the OB office. So I'm just curious to know, did that require a lot of education on your end? And how do you think this could be possibly replicated in other hospital systems?
So I think that is a great question. And I think that we are kind of getting to that point. So a lot of the stuff that we've published so far has been retrospective data, so data that already exists. And now we already started a pilot study where we are actively enrolling these women and then obtaining an ECG. So even though we are working collaboratively with our obstetricians, they are not the ones having to perform the ECG because this is a research setting, right? So we are having the ECG still performed in kind of like the cardiovascular environment. We schedule them for an ECG, and then we perform the analysis on the back end, and we schedule them for an echocardiogram as well, because we want to confirm that our predictions is actually matching what is happening with the echo. What I see for this moving forward is that if this tool works, and which is our hope, that we can incorporate this as a routine screening procedure in OB practice, then yes, we will probably need to start educating our OBs about, getting an ECG. The other thing we want to do is make it easy for them. We also do not want to burden an OB doctor with having to diagnose a STEMI on the ECG. So there needs to be kind of like a collaborative approach. And we know now that cardiobstetrics is a new and emerging field. There really needs to be a relationship between the obstetrician and the cardiologist. What do I go for answers? If I order this ECG and the predictions are normal, but there's something else abnormal on the ECG, then what happens? What is the next step? What do we do? So they really do have to work together for us to see, success in this area.
Yeah, and you bring up a wonderful point. It looks like Annette did have a question as well, which I'm going to let her answer.
Just one. No, this has all been very good, very interesting, very eye-opening. One of the questions I have, as you probably know, Demi, I'm very interested in sub-Saharan Africa and sort of democratizing care there and other developing countries. So where do you see AI fitting into care in developing countries?
That's a wonderful question, Annette. And, I'm happy to actually let you know that we just got some funding actually to extend our pilot study to enroll obstetric patients in Nigeria. We will be starting in Nigeria because Nigeria has the highest rate of peripartum cardiomyopathy in the world. So we want to make sure that this tool, if you take it to a really high risk population, how well does it function when you take it outside of the US? So that's one of the things that we're hoping for. If we're able to show that this tool is effective in diverse patient populations and international sites in low, resource poor settings, then can we use this to actually improve care? And I think that that would be a huge game changer if we are able to demonstrate this. So yes, I'm on the same page with you on that.
Thank you. That's awesome. And if there are no other questions, I will go ahead and close out. I want to first thank everyone who is on the call today for their attendance. I'd like to especially thank Drs. Doroge and Dr. Adedinshewo for tonight's program. We would also like to thank the ABC leadership for their support of this program. But also please join us in our year-long campaign, We Are the Faces of Black Maternal Health, where our ABC members share how they've been impacted by the Black maternal health crisis. You can find us at wearethefaces.abcardio.org. And with that, I'll be signing off. Good night, everyone.